do with the acute abdomen and any abdominal pain, you have to consider all differentials before you come to gallbladder. So I'll be talking about it in the context of a lot of other conditions because it doesn't present in isolation. So like I said, I'm Joe Wood. I'm a fifth year at the moment, student doctor. And what I've found useful in previous presentations is in the bottom right hand corner, I put the source of where I got some info from. So there's some really good websites, especially for Rising for finals. So Teach Me Surgery, BMJ Best Practice, NICE guidelines. So just keep a look in the bottom right hand corner for some useful websites. Okay. So what we're going to cover today. So some basic anatomy. For those of you in later years, this might be a bit of a throwback, but it's useful to remember. Some basic physiology, pathophysiology, and then gallbladder disorders. So ones that are important for you to know, and maybe some rare ones as well. So how they present, how to examine, what investigations would you order, and how would you manage them. So that's what we're going to be covering today. Okay. So just a little quick exercise, 1 to 6. Just jot down on a piece of paper what you think these structures are called. So I'll give you a clue. It's the gallbladder is the big circle thing on the right, at the left-hand side of the image. So try and label it. I'll give you about 25 seconds, and then I'll go through the answers. Okay. So the gallbladder, like I said, on the left, that's the gallbladder. The cystic duct comes from the gallbladder and meets the common hepatic duct. The common hepatic duct further up is the left and right hepatic ducts. And then it goes into the common bile duct, where it meets the pancreatic duct at the ampulla ovata, where it goes into the duodenum. I'm just revising the anatomy because gallstone pathology is very dependent on knowledge of this anatomy, because where a gallstone is lodged will cause a different disorder. So it's important to have this sort of in the back of your head where everything roughly goes. So yeah, that's the basic anatomy. So it lies beneath the liver in something called the gallbladder fossa. Like I said, the common hepatic duct drains from the left and right hepatic ducts. So the lymph nodes drain into the cystic, which then goes into the hepatic lymph nodes. It receives its blood supply initially from the celiac trunk, which goes to the hepatic artery, and the right hepatic artery, and then the cystic artery. And the pancreatic and common bile duct unionize at the ampulla ovata, where it enters the duodenum, the second section. Okay, that just basically puts it in context what I'm going to be talking about today. So when food enters the digestive tract, cholecystokinin is released by the small intestine, which causes the gallbladder to contract. So bile is released into the duodenum. Bile is made up of many components, most notably cholesterol, phospholipids, and pigments. And it's the oversaturation of these components which leads to the formation of gallstones. And the main types are just there, a cholesterol, pigment, or mixed stones. Okay. So risk factors for gallstone disease. You might have heard of this acronym before, but it's the 5 Fs. So the first one is fat, female, fertile, 40, and family history. So people who carry a bit of extra fat are more at risk. Female patients are. People who are fertile, 40, or if they have a family history of gallstone disease. So when you're taking history from a patient or you're clerking them in, just have this in the back of your mind, you know, if they present with abdominal pain, could this be gallstone pathology? So it's a good, quick way of remembering it for exams and OSCEs and things like that. So to start off with a case. So a 46-year-old male patient presents to AED and he's got constant right upper quadrant pain. So just brainstorm some differentials for what might cause a right upper quadrant pain. So I put there, so liver, an abscess or hepatitis can cause a right upper quadrant pain. Try and have a think of any more you can think of that might cause right upper quadrant pain. Just give you a few seconds and I'll just go through some ideas I had. It's not exhaustive, but it's good to be systematic. So I thought of respiratory. So if you've got a lower lobe pneumonia, you might get some right upper quadrant pain. Pancreatitis, although classically it's epigastric pain, you might also get some right upper quadrant pain with that. Gallstone disease, like we're talking about today, cholecystitis, cholangitis, biliary colic, peptic ulcer disease, and even renal colic or pyelonephritis. It's important to think about all the different organs that are in the abdomen, because pain is sometimes non-specific and it's not always what's directly beneath the skin at that point which might be causing the pain. So it's important to have a rough idea of what might be causing different problems. Okay, so here's a little bit more of the history. So it's constant at the moment and it doesn't radiate anywhere. This patient feels nauseated, but he hasn't vomited. It came on late in the evening, around about 9 o'clock, whilst watching TV, as he has a background of hypertension and he has a high BMI. So his OBS are as follows: a bit tachycardic, saturating fine, 123/86 BP. So what do we want to rule in and out on examination? So we know that he's got right upper quadrant pain. He's feeling nauseous, a bit tachycardic, that might be from the pain. We want to sort of examine him now. So it's not exhaustive examination. Of course, you do a full A to E assessment and a proper abdominal examination, but some key points from the examination I think you should note are, so when you palpate, where is it tender? Try and locate specifically where that pain is. Rebound tenderness, I'm sure you've heard of this. It is when you palpate and you release your hand quickly, and that causes tenderness. That's a sign of peritonism, and that can signify an acute abdomen. So something serious. You can get it in a number of abdominal conditions such as appendicitis and things like that. So guarding is a patient voluntary or involuntary guarding. So voluntary basically means the patient's guarding, so maybe they can feel the pain, so are tensing their muscles so it doesn't cause them any more pain. Or involuntary guarding, which is another sign of inflammation of the peritoneum. An important sign to remember for gallstone pathology is Murphy's sign. So this is positive in acute cholecystitis. So firstly, what you do is you press on the lower, the left upper quadrant, just underneath the costal margin as the patient inspires. Shouldn't elicit pain. And then you move to the right-hand side of the abdomen, do the same thing, but in acute cholecystitis, you should catch the breath and cause just an increase in pain. So that's an important sign to remember. Other points in examination are really important: percussion, auscultation, organ-specific palpation, things like that. So back to the patient we were talking about. So we've got the history, you do an A to E assessment, we've got a full set of observations. So what do we think at the moment the problem might be? I'll go back to the history, but those are some differentials that we have. So what do you think the Murphy's sign was negative in this patient? So what do you think? Put in the chat what you think the answer is. Okay. So this patient would have biliary colic. So they feel nauseated, they have this pain. It came on after in the evening. So this patient's probably had dinner, maybe a fatty foods, and it suddenly come on. This patient's also in their 40s. They've got a high BMI. So they've got a lot of risk factors. So we're thinking towards biliary colic. Murphy's sign was negative, so it can't be acute cholecystitis. Acute cholangitis presents more with fever and things like that, and acute pancreatitis, classically, like I said before, epigastric pain, might have a history of excess alcohol use. So this patient just had biliary colic. Okay, so a little bit more. So it's quite common, roughly 10 to 14% of the population. I can't remember whether that's have gallstones or biliary colic, but gallstones are very popular in the population in the West. So gallstone is impacted in the gallbladder neck in biliary colic, and it causes this sort of colicky pain. Typically right upper quadrant, it can radiate to the back. So that's something to remember. And it's typically triggered by fatty foods. So if a patient presents after they've eaten dinner and they complain of this sort of pain, they might have had it in the past, but never gone to a doctor about it. So it's always good to ask the history. So management of biliary colic, of course, you do a full A to E assessment, investigate them, which I'll come on to later, what orders you do. But basically analgesia at this point, so start off with simple things and then work your way up the WHO analgesic ladder. Lifestyle education, so it's important to lose weight, exercise, and if fatty foods are a trigger, try and limit them. There is a high chance of complications if a patient has biliary colic. So although it's impacted in the gallbladder and neck, the gallstone does not leave the gallbladder. So there's a potential in the future it could get lodged in the CBD and cause maybe acute cholecystitis or cholangitis in future. So NICE recommends that laparoscopic cholecystectomy is offered to patients who have biliary colic. So acute cholecystitis, this is gallbladder inflammation, and it's often due to a gallstone in the cystic duct. So if you remember back from the anatomy, that's the duct that leaves the gallbladder directly, where it joins up with the common hepatic duct. So what happens is the stone gets lodged in the cystic duct. As a result, when the gallbladder contracts in response to eating food, the pressure increases, causing prostaglandin secretion, fluid buildup. Inflammation ensues, causing a lot of pain, can radiate to the back again, scapular, sharp in nature. And as I said before, Murphy's sign positive. You can get fever sometimes, nausea, vomiting. These patients appear very unwell and in a lot of pain. So things to bear in mind with these, again, A to E assessment with all of these patients. Start them on IV antibiotics if indicated. Like I said before, analgesia if they're feeling sick, antiemetic. And with these patients, laparoscopic cholecystectomy again, within 1 week, but ideally as soon as possible. So really within 72 hours, if possible. Okay, and acute cholangitis or ascending cholangitis. This is inflammation of the bile duct, and it's usually due to a bacterial infection. So risk factors for this are if you have a tumour nearby, such as of the pancreas, of the gallbladder itself, duodenum. If you have any strictures, gallstones causing stasis of bile. If you've had previous injury to the bile duct, such as if you've had ERCP for stone retrieval or any other purpose in the past, and also parasites. An example of that is roundworm. So the Tokyo guidelines are useful for diagnosis and management. You can look at these in your own time. They are quite useful. So just have a look. But the gold standard investigation, so that should say MRCP, for all gallstone pathology is MRCP. So management, again, A to E. I hope I'm driving that home to you. It's really important to do a full A to E assessment. Oxygen if indicated, IV fluids, broad spectrum antibiotics. So these patients, have really high fevers, really in a lot of pain. So first line is non-surgical biliary decompression. That comprises of a lot of multiple procedures with quite complicated names. So I think it's important to look that up, but important to realise that don't rush in with surgical intervention immediately. That's a last resort in an ascending cholangitis. But initiate sepsis 6 within an hour on these patients. So sepsis 6 includes the anagram buffalo. I don't know if you've heard that before. So blood cultures, measure urea, fluids, antibiotics, lactate, oxygen, and urine in and out, sorry, not urea. So that's really important because it is a bacterial infection usually in these patients. So key features to elicit from a patient with ascending cholangitis is something called Charcot's triad. So try and think which one of these is the correct option. So what is Charcot's triad? I'll just give you a second. Perfect, somebody in the chat got it right. So yep, number 2. So abdominal pain, jaundice and fever are classic signs of ascending cholangitis. This can be extended to Raynaud's pentad, which is abdominal pain, jaundice and fever, but with the added options of confusion and hypotension as well. It's a good triad to learn. So I just thought I'd do a quick summary of the ones that we talked about so far. So cholangitis, cholecystitis, and biliary colic. So cholangitis, you get all 3, the pain, the fever, and jaundice. Cholecystitis, right upper quadrant pain and fever. And with biliary colic, you usually just, you can sometimes get a fever, but usually it's just the right upper quadrant pain. So when investigating gallstone pathology, it's important to rule out other things going on because there's loads of different causes for abdominal pain. So I've put some of the investigations you would do. So first off, you do an FBC, so looking for hemoglobin, looking for white cells, platelets, things like that. In sort of ascending cholangitis, you might have a raised white cells, or in acute cholecystitis. UNEs, check renal function. If you're going to start them on any antibiotics or other medications, it's good to have a baseline of their kidney function. So LFTs, so you want to know what their bilirubin is, ALP, ALT, gamma GT as well. CRP is a marker for inflammation, so that may be raised. You want to know your analysis, want to know if there's any sort of, it might maybe a UTI, so you want to rule that out as a cause of abdominal pain. Pyelonephritis maybe as well. Amylase is another important test to do, exclude pancreatitis. So with acute pancreatitis, you have a raised amylase. Like I've just written there, gallstones are a common cause of acute pancreatitis. It's not just alcohol excess. So it's important to bear that in mind as well. Other ones include pregnancy tests. So all women should be assumed to be pregnant until proven otherwise. So always rule that out, especially in the context of potential ectopic, which can cause abdominal pain. If you're concerned a patient has sepsis, maybe you're thinking they have ascending cholangitis, they have a high-grade fever, they look really unwell, maybe hypertensive, tachycardic, it might be worth doing blood cultures as part of the sepsis 6. ABGs are useful when calculating the Glasgow pancreatitis score. Clotting, all acutely unwell patients should really have an ECG as well. So some other ones, a transabdominal ultrasound. So things you were looking for is gallbladder wall thickening, maybe fluid around the gallbladder, and looking for the gallstones themselves. So chest X-ray. So if you're concerned that maybe a patient has a perforation, or maybe, like I said before, a lower lobe pneumonia, maybe they've got respiratory symptoms, maybe crackly on the chest, you want to check that. If you're concerned a patient has maybe small bowel obstruction or something like that, or large bowel obstruction, abdominal X-ray really useful. MRCP, like I said before, is the gold standard for gallstone pathology. An abdominal CT as well. Obviously, it's a lot more high fidelity as well, but MRCP is the gold standard. And if a patient is query surgery, it might be worth doing a surgical workup for them as well. So it sounds like quite a lot of investigations going on, starting from the bedside and then working your way up. But it's important to rule things out, because there can be cases where there's multiple likely differentials. So we'll go through some now. So here are some examples that I could think of. So like we talked about, the top 3 are gallstone related stuff: acute pancreatitis, severe upper abdominal pain, nausea, vomiting. You can have a gallstone ileus, which is obstruction caused by a gallstone. So you have symptoms of bowel obstruction, so the nausea, vomiting, constipation, abdominal distension. Appendicitis, so pressing in the left lower quadrant can cause pain at McBurney's point. So a sign positive, rebound tenderness, potinism, nausea, vomiting. Ectopic, really something you cannot miss. So they might just present with just abdominal pain. They might not be hemodynamically unstable, but they might be as if maybe it's ruptured. So yeah, it's important to quantify beta HCG. Bowel obstruction as well can be distended, constipated, vomiting, abdominal pain, the 4 cardinal signs of bowel obstruction. So it's important to have these things in the back of your head, but it's not exhaustive. So NICE guidelines, what do they say about gallstone disease? So all patients should have LFTs and ultrasounds, but like I said before, you do a lot more than that to rule out other things. But so you consider an MRCP, which is the gold standard, if ultrasound doesn't detect common bile stones, but the bile duct is dilated and or LFTs are abnormal. So you'd start off by doing an ultrasound, and if that doesn't give a definitive answer, you move to MRCP. Endoscopic ultrasound can be used if MRCP isn't fully conclusive. So gallstones. So if a patient is just found to have gallstones accidentally for whatever reason, but they don't have any symptoms, their LFTs are normal, you know, they're fitting well, they just have a few. Like I said before, a lot of people in the general population have gallstones but never have symptoms. So reassure them that there's no need to treat at the moment, but if symptoms develop, either come into A&E or speak to your GP about it, depending on how severe it is. But nothing for asymptomatic gallstones. If they are symptomatic, like I said before, like biliary colic, laparoscopic cholecystectomy is offered to them. In acute cholecystitis, like I said before, within 1 week, but earlier if possible, so within 72 hours ideally. Gallbladder empyema, so you can do percutaneous, so through the skin, cholecystostomy, sorry, if surgery is contraindicated, but this should be reassessed in patients if they get better and they become well enough for surgery. So it should be reviewed. So if the stone is in the bile duct, here are some important things, like I said before. So if a stone is in the bile duct, whether it's symptomatic or asymptomatic, it requires an operation, laparoscopic cholecystectomy. Those the asymptomatic gallstones I was talking about before are when they're in the gallbladder itself, not in the duct, because if it's in the duct, obviously that's a blockage and it'll eventually cause a problem if it hasn't already. So you can do bile duct clearance. You can either do this at the time of the cholecystectomy or during the ERCP. Like I said before, if bile duct cannot be cleared with the ERCP, you can do stenting, but that's not a definitive solution. It's only temporary. So general information to tell patients is avoid food and drink problem foods, fatty foods, things like that, and safety netting. So if new symptoms recur, speak to GP. An important thing to mention to somebody who's had a cholecystectomy is that if they do in future develop right upper quadrant pain, this may be a stone that's left in a it can be a stone left in a one of the ducts. So it's important to make them aware of that if they do develop pain in the future. So other important management, like I've said before, analgesia. These patients are in a lot of pain, so prescribe appropriate analgesia. Antiemetics if they feel sick. Antispasmodics. If these patients are having surgery, they might be nil by mouth, so prescribing IV fluids is important. If they are really unwell when they come in and they're hypertensive, prescribing fluids is important, as well as part of the sepsis 6, for instance, for ascending cholangitis. And consider antibiotics, such as acute cholecystitis and ascending cholangitis. So here's a second case. So it's a 42-year-old female patient. She comes to the A&E department. She's got right upper quadrant pain, high-grade fever. She notices she's been jaundiced, and she's very tender in the right upper quadrant, but her lungs are clear, heart sounds normal. So there are observations, a bit tachycardic, and she's got a bit of a fever, 38.7. Okay. So just brainstorm what type of tests would we want to organise for this patient. Okay. So this is a case of something called Merisi syndrome. It's quite rare, but it's something important to know about. So what happens is a gallstone can get lodged in the cystic duct, which can put pressure on the common hepatic duct. So this is extrinsic compression, so not within the hepatic duct itself, it's external to it in the cystic duct. If it's been there a while, it can cause necrosis and erosions and buildup of swelling and fluid around the cystic duct, putting pressure on the common hepatic duct. And eventually it can result in a fistula. So it's quite a serious syndrome. There are multiple different types of Merisi syndrome. So have a look at them, learn what the different types are. But this patient was jaundiced, as you can imagine, looking at where it's compressing on the common hepatic duct. You can see why a patient like this would be jaundiced. Like I said, whilst it's not a common disorder, I think it's important to learn at medical school what it is, because it's one of those rare niche things that you should know about. Okay, so I've got a number of questions to just make sure you've learned something, hopefully, from the talk. So a patient is accidentally found to have gallstones on abdo ultrasound, but they don't have any symptoms. What is the correct management for them? So do they have the gallbladder removed, bile duct clearance, no treatment with safety netting, or do we stent their bile duct? So like I said, a patient like this does not need any treatment. If they have gallstones in the gallbladder with no symptoms, just, tell them that, if they do experience right upper quadrant pain, or any abdominal pain, to come to A&E or speak to the GP. So which of the following is not one of the 5 Fs of gallstone disease risk? So 50s, female, family history, or fertile. So the answer is 50s. It's actually patients in their 40s which have the highest risk of gallstone disease. Okay, so a patient presents with intermittent right upper quadrant pain, exacerbated by fatty foods. What is the most likely diagnosis? Is it cholecystitis, colic, cholangitis, or an empyema? So this patient has right upper quadrant pain after eating fatty foods. The right upper quadrant pain eventually resolves, but it's exacerbated when she eats. So it sounds like biliary colic. So a 54-year-old male patient presents with severe upper abdominal pain. They've been using paracetamol, but it doesn't seem to be doing anything at all. Bloods reveal a raised amylase. What is the most likely diagnosis? So yeah, the key thing in this question, sorry, I've just got a message on the chat. Yeah, Bethany's right, it's pancreatitis, perfect. So raised amylase is the important thing to note in this question. So a 23-year-old female patient presents to A&E with severe right-sided abdominal pain. They're hypotensive and they're tachycardic. What thing do we need to exclude urgently? Yeah, perfect, ectopic. So in a woman of childbearing age, it's really important to rule that out, especially as they seem to be hemodynamically unstable. So you're on a ward round with a consultant general surgeon. So when the consultant, when she presses the left lower quadrant of the abdomen, it causes pain in the right lower quadrant. What is this sign called? Is it Murphy's sign, the psoas sign, Rovsing's sign, or McBurney's? Yeah, perfect. Rovsing's sign. Okay, so Murphy's sign, if you remember, is when you push down just underneath the costal margin. These other signs are for identifying acute appendicitis, but important to remember these signs. There are others which you need to learn, but having that in the back of your mind is important. So question 7, a 59-year-old female patient has got colicky right upper quadrant pain. She's had pyrexia, tachycardia, nauseated, vomiting, and noted to be jaundiced. So after a workup, she's found to have ascending cholangitis. What is the most common organism causing ascending cholangitis? Okay, so the answer is E. coli. Klebsiella and Enterococcus are also causes of ascending cholangitis, but E. coli out of that list is the most common. So what, I've mentioned it before, but what is the gold standard imaging technique for gallstone pathology? Is it an abdominal X-ray, abdominal ultrasound, endoscopic retrograde cholangiopancreatography, or magnetic resonance cholangiopancreatography? Perfect, yeah, MRCP. Sorry about the typo before, it is MRCP. So hopefully that has been just short and sweet, just to highlight the key important things that you need to know. So a few key points at the end. Patients who present with new onset abdominal pain, it should be taken seriously. Thorough history, A2E assessment, and then investigate appropriately. Be thorough, always do an A2E assessment. start with airway, breathing, circulation, disability, exposure, and as part of that you would do an abdominal examination. Assess the patient fully, basically. So all abdominal pain differentials should be considered when thinking about gallstone disease. So hopefully I've introduced that point to you. So pain can be non-specific. A patient might have gallstone histology but have epigastric pain. Pain might not radiate to the back. So it's important, especially in younger people and children, to think about other causes. So MRCP is the gold standard. Have a look at the NICE guidelines yourself. They are useful, as well as some of the websites that I've put in the bottom right-hand corner. They make it really simple to understand with really good pictures and visuals. So yeah, that's everything that I wanted to say. And thank you for coming. I hope you learned something. I hope you found it useful. I think there's a link in the chat. If you could please give me some feedback. And thank you for attending. That's been really great.